about PMOS, ovulation, and how to improve your chances of ovulating naturally when you have a history of PMOS. So my background, I'm Katie, I'm a nurse practitioner, and I'm also a fertility consultant. So I help people get pregnant faster depending on what is going on with their bodies. And if we don't know, helping people figure that out. So if you're interested in working one-on-one, taking a course, check out my website. I'd love to chat. Okay, anyway, so let's kind of dig into understanding and helping you understand why are you not ovulating regularly if you have PMOS, what PMOS or formerly PCOS actually is, why ovulation is the most important step for pregnancy and what that means related to PMOS, and what prevents ovulation and ways to improve ovulation. Okay, so if you've been told that you have PCOS or if you've been told that you have PMOS and you were told to lose weight or that you need letrozole, we're missing a big part of the picture. Okay, so you don't get pregnant because you have periods. You get pregnant because you ovulate, okay? And so the biggest mistake that I kind of see that women are focusing on with PMOS is fixing and getting a period, not fixing the reason that they're not ovulating. So what is PMOS? So it is it was formerly called PCOS, which is Polycystic Ovarian Syndrome. And now it's Polycystic Metabolic Ovary Syndrome, okay? So the reason that it has changed is because we weren't having a bunch of cysts. The problem is more of a metabolic disorder that makes your ultrasound look like you have cysts. And that's the only thing that's like cystic about it. And what they were looking at was not cyst, it was follicles. And so they were seeing a bunch of little follicles on ultrasound, and follicles look like cysts. Cysts are just fluid-filled sacs. And so they were kind of, it was mislabeled. So PMOS affects 1 in 10 women, and it is the leading cause for ovulatory infertility. Okay, so a lot of times people are kind of pushed towards doing IVF with PMOS because of that history. And so we know that it's going to be more challenging. And unfortunately, OBGYNs and PCPs don't often have a lot of time to really kind of dig in deep and understand what's going on with your body. What can we do to improve it? How can we kind of get your body working better? So it's not simply a hormone disorder. It is a metabolic disorder that impacts hormones. Okay. So why does ovulation matter? So if you don't ovulate, there's no egg that is released to be able to be fertilized. And so when we don't have that release, we don't have that progesterone production. And so we're going to have a much lower chance of implantation. We're going to have irregular cycles, which make it very difficult to determine what are your fertile days. And thus, it's difficult to get pregnant. So in a normal functioning reproductive system, what we should see is that the brain signals and tells the ovary, hey, it's time to release an egg. And so we will have ovulation. And then after ovulation, your body starts making progesterone so that we can support that pregnancy if egg is fertilized and if embryo is able to implant. Okay. In PMOS, what happens is the brain is going, hi, I'm not really getting a strong signal because of this hormone imbalance, okay? So the egg is kind of stalling and we don't have ovulation. So the reason that women with PMOS don't ovulate is for several reasons, okay? The first that we're going to go into is insulin resistance. So insulin is not just about diabetes. It is about more of a communication that's going on in the body. So high insulin is telling the ovaries, hey, make more testosterone. More testosterone starts to interfere with normal follicle development, okay? So instead of one follicle maturing, many tiny follicles will start growing, but none of them finish, okay? It's like they're all kind of getting a little bit of this signal, and instead of one egg or follicle growing and develop, we'll see multiple tiny little follicles that begin to grow, but none of them finish. None of them can be completed. So this is why, again, that ultrasound looks polycystic, is because we're seeing multiple follicles. This hair's driving me a little cry. On that ultrasound if we're looking for somebody that has PMOS. Okay. With that higher testosterone, we're also going to see higher androgens. Okay, so this is going to mean that those people with PMOS are more likely to have acne, facial hair that you do not want, scalp hair loss, oilier skin, irregular periods, and heavy periods. They're not necessarily painful periods. Usually you don't have a lot of discomfort, but they can be very heavy. So those are some things to know, and that interacts with or impacts ovulation itself, okay? Another thing that we're going to see with PMOS is chronic inflammation. And so inflammation is going to impact that hormone signaling. And inflammation is often a cause for some of these issues. So poor sleep, stress, a highly processed diet, obesity. We're going to see a lot more inflammation. We're going to see smoking. That's going to contribute to worsening inflammation. So all of those things are going to impact it. Then we've got the other issue regarding hormones is going to be an elevated LH, which is luteinizing hormone. So people with PMOS have chronically elevated luteinizing hormone. And so instead of getting like one good surge, we just see that it kind of continues to stay high because the brain is having confusing signals to the ovaries. So follicles aren't able to mature appropriately. So one kind of question or myth that I see though is, do I have to lose weight to ovulate? Not necessarily. So weight loss is not the treatment. Weight loss is usually kind of a side effect of improving that metabolic health. For a lot of people, weight loss does lead to some improvement with PMOS and increase of likelihood of going to start ovulating regularly. However, I would never just tell someone to go lose weight and that's going to fix their PMOS. Okay, that is, first of all, an incredibly difficult thing. Quitting smoking and losing weight are some of the hardest things to do, period. Okay, and so when you have somebody who has a metabolic disorder, not just an overeating disorder, okay? We have people that have metabolic disorders. You don't just go tell them to go lose weight, okay? That's very frustrating. And it's very discouraging as a patient to hear, just go lose weight, okay? So weight loss is not the treatment. We want to improve metabolic health. Some people can still ovulate even at higher weights, okay? So, and some lean women can have really severe PMOS. It's not just related to like your BMI or your weight. So the goal that I have for my PMOS clients is going to be improving their insulin sensitivity, not just, I've got to lose 5 pounds or 10 pounds or whatever that is. So when we need to improve the insulin sensitivity, how are we going to do that? Okay. First is going to be through diet, and really what I do with my clients is I have them fill out a food log and we start really paying attention to what are you eating every day? How much fiber are you getting in a day? How much protein are you getting in a day? How much fluid are we drinking in a day? Where do we need to start pairing meals differently? Are we getting enough calories? Are we getting too many calories? What are your habits? Because I want to look at that and understand that. The first thing, kind of overlying thing, is protein. I'm so sick of talking about protein and hearing about protein. Blah. Okay, but it is what it is, so we have to discuss it. Also, in my course, we go into all of this. I let you show you kind of exactly how to break all of this down and what you need to be looking for based on your history, your labs, etc. But kind of as a general rule, we want to start aiming for at least 100 grams of protein per day. And that can be really hard, and that's different for everybody depending on your weight, depending on your goals, etc. But we really kind of want to aim to get about 30 grams of protein per meal, and then we're already, at 90 per day. And then getting some snacks or adding some extra ways to get some protein in there throughout the day outside of meals can be really helpful. So kind of thinking like, where can I get 30 grams each meal? And then we know that you're going to be at a better place than skipping meals or just grabbing a salad may not have enough protein in it. So aiming for 100 per day, prioritizing breakfast. I love a protein coffee, do your coffee with a scoop of protein powder. I think that's a great way to start the day and be able to kind of know that you're starting off with a solid 30 grams. Because for a lot of us, getting enough protein every day is very challenging. So prioritizing your breakfast, and that is going to really help stabilize glucose spikes throughout the day. The other thing is fiber. So increasing your vegetables, beans, seeds, fruit. Fiber is important because it helps really slow the absorption of glucose. So if you think about just putting like a piece of bread into water and how quickly that breaks up and like becomes mush, versus if we are mixing that with like some beans and corn, it's that fiber is going to slow down that process because your body's going to start breaking it down altogether. And that way, instead of just quickly receiving a huge dose of glucose, that fiber really helps slow it down. Another thing that's really important that I've also been working on personally is strength training, because this is just one of the best interventions. And it's also really frustrating because it takes a while to build muscle. It is not something that happens overnight. You have to be very consistent with this. And this is something that is a habit change. It's a lifestyle change. It is not just like a temporary thing. And so for me, finding the time to actually lift weights has been a really big challenge for the last 7 years. And so kind of working on, okay, what does your schedule look like? How are we going to fit this in? How can we do this safely? What kind of support do you need? What kind of resources do you have to be able to really understand what you need to do individually? But building muscle is a great way because it does several things. It improves insulin sensitivity because your body is able to use that glucose more quickly. When you have more lean muscle mass, your metabolism starts to improve. The way that your body processes food starts to improve. The way that your body uses those glucose starts to improve, because when you're consistently engaging these big muscles groups, your body burns off that glucose and it learns how to use your fuel better. But it takes a long time, and that can be really frustrating. So I don't like to measure on the scale your weight loss. I like to measure, when we are looking at weight training, what are your gains? How much did you start lifting in the beginning and where are you at now? So I want to see that we are having some progress in lifting heavy and that we are adding to that individually. And I know I feel like when I go to the gym now, I'm working on the barbells.
Wow.
It's just kind of like so crazy because I use this 45-pound bar, and then I had like a 2.5-pound weight and a 2.5-pound weight to do my like shoulder press things. And I'm like, oh my God, this looks so puny. But also from where I started from, it's come a long way. So you have to give yourself grace. You have to be patient, and you have to be persistent. And it's a pain, but it's just the way that it is. Another thing that's really important with PMOS is walking, especially after meals. So walking for 10 to 15 minutes after every meal makes a really big difference regarding glucose spikes and keeping glucose stable, because as your body is moving, it is able to process that sugar quickly rather than store it. So walking for 10 to 15 minutes after a meal is important. Sleep is important because that is where we are, our body is repairing itself. And when we don't get good sleep, we are having more insulin resistance. We're having more glucose spikes. We're going to have raised cortisol, and cortisol raises throughout the day are natural. They're normal. It's a normal response. We're not going to stop cortisol, but that consistent, up and down makes cravings for food worse. And so, getting a good night's sleep is really important. And so if you've got sleep issues, insomnia, sleep apnea, poor sleep hygiene is still just a weird word to me. Like, hygienic sleep. That doesn't make sense, but that's just the word that we use. But like a good bedtime routine is important. Stress does not directly cause PMOS, but it is going to make it worse. So I always tell a story about my glucose and how I watched my glucose spike. I got up one morning because the kid was up, and I panicked a little bit for whatever reason because half asleep, half awake, and I had a huge glucose spike. And when I stay stressed, when I've had a stressful week, I will know that my glucose are much higher. It's actually crazy. So when I am in a stressful situation, whether, home life or work life, I can see it on my glucose monitor. So we've got to figure out where's the stress coming from and what can we do to minimize it or manage it. So yeah, those are some of the big ones. When it comes to like supplementation regarding PMOS, you always have to discuss this with your provider. There are some people with PMOS that I use different protocols for. Again, this is mentioned in my course for you to kind of help navigate some of this, and you always need to review this with your provider. But myo-inositol is probably my number one most used one. And we can link below to the one that I like. Hopefully we can add that. Make that note. So the myo-inositol helps improve ovulation. It helps with insulin resistance, and it helps with egg quality. If we have a vitamin D deficiency, which I also find in my PMOS clients often, that is going to make ovulation more difficult because your body just doesn't have what it needs. Omega-3s are great. They can help reduce inflammation. I'd say most of my clients are on an omega-3 fatty acid. I would say berberine is one that we use often for PMOS because it can help with that insulin sensitivity. Magnesium can help a lot for people, especially if deficient. That can help with glucose regulation. Taking that at bedtime can help with sleep. So if we've got sleep issues, sometimes that's appropriate. And then N-acetylcysteine, NAC, growing evidence surrounding that and how that can help. So that has been shown to really help improve insulin sensitivity, ovulation, and distress that can be impacting our ovary and egg quality. Some of the other more common treatments for PMOS and ovulation, letrozole is going to be usually your first medication, first line that is going to be used. It works better than Clomid for people that have PMOS, and that can help people start ovulating. So can metformin. A lot of my clients don't want to be on medications, but metformin is one that can really help with insulin resistance, help regain cycle consistency, especially if we have somebody who's in that prediabetes or diabetes category. So metformin is a great drug. And it is I think it's derived from a plant. I think it comes from like a natural source. It's something that we've like turned into a medication that way. GLP-1 medications are some that are often used when I have somebody who really needs to tighten up insulin sensitivity. It also helps with weight loss. It can help just kind of be a reset for people, especially because if I have someone who is older and we have a shorter timeline of being able to get pregnant before we have to go that IVF route, that can be a good option. But it does need to be stopped before pregnancy because we're still learning and understanding how this med affects mom, how it affects baby, etc. So once we've kind of gotten body straight, how do I know if I am ovulating? How am I actually ovulating? So a period doesn't necessarily mean that you're ovulating. What we want to look at are changes. So are we going to see that the basal body temperature has a spike? That's going to indicate signs of possible ovulation. A luteinizing hormone strip, are we seeing that we're having spikes, or are they consistent? I really like the tool Mira. That's a great tool for tracking and determining am I ovulating? And in my course, you also get a discount code for the Mira and the strips. I think you get 40% off the strip subscriptions. Checking a mid-luteal progesterone, and that can be challenging to get when we are looking at people with PMOS because their cycles are not a consistent 28 days. And so usually for somebody who has a 28-day cycle, we'd want to draw that progesterone on cycle day 21. But if your cycles are abnormal or they're long, it can be different to really understand and be able to get that lab. And then cycle tracking, kind of keep on paying attention to that. So some common mistakes are only focusing on getting your period, taking birth control to fix PMOS. It helps suppress symptoms and it can help manage those symptoms, but it doesn't cure those metabolic issues. And so we want to make sure that we're addressing both sides of those, addressing the symptoms and also kind of getting to the underlying cause and really treating that too. Mistake 3, only taking letrozole every month and not actually working on improving insulin sensitivity, glucose control, and really kind of giving a good environment for the egg, because the letrozole can help you ovulate, but if we have poor egg quality, it's still going to be difficult to get pregnant. And then another mistake is waiting so long. A lot of times people are instructed to just lose weight and come back. And again, that's very difficult to be successful. So I think that, if you have that diagnosis or you're concerned for that diagnosis, it's good to get it tight on the front end and not wait until you are stressed and trying to get pregnant to really address that. When it comes to when to seek help, I think that, if you're having cycles that are consistently irregular or greater than about 31, 32 days, if we're having cycles that are 35 days, that's concerning. If we're not having at least 8 cycles a year, that is concerning. If we do labs and you have elevated testosterone, if you've been trying to get pregnant for, 6 months and we're not seeing anything, or we have some irregularities, if we've got recurrent miscarriage issues, we need to address all of that. So PMS is not just having irregular cycles. It is not just about being diabetic or pre-diabetic or being overweight, because so many people with PMOS can be irregular weight, underweight, etc. We want to make sure that you're ovulating. That's our goal. Okay. And so what happens by kind of getting to the root cause and understanding what's going on with your body, that's how we can really improve your chances of ovulating on your own and getting pregnant on your own. And even adding some medication sometimes is really beneficial, but we want to make sure that your body, once you are pregnant, is going to be able to support that pregnancy through health. So if you've been told to just keep trying and you're not actually understanding what's going on with your body, or you feel like something is wrong and we need to really dive into your hormones and labs and insulin and glucose, I love helping people with this. So if you're interested in working one-to-one, let's set up a free consult. If you kind of want to take your time and do this a little bit more slowly, there is a great course on my website. So check that out. Anyways, drop your questions and comments below so we can keep having great topics. Thanks so much. We'll see you next time.